created streamlined educational materials with our clinician partners, and we work with electronic health record, scheduling platform, and clinical decision support partners to make it easier for clinicians to get the information into their workflow that they need to vaccinate their patients. CDC also hosted a series of webinars with clinicians to help clinics prepare for the fall and winter respiratory season, including a recent webinar with the AMA that was viewed over 17,000 times in the first 2 days alone. We, of course, at CDC continue to closely track the changes to the virus that cause COVID and make that information available to the public. The good news is so far that the updated vaccine closely matches the KP3 family of viruses that continues to grow in dominance. CDC remains dedicated to sharing timely and clear information so that people know what's happening in their communities and are empowered to take preventive action. Last year, we launched for the first time an interactive respiratory illness data channel that integrated data from multiple sources to describe respiratory illness activity across the country. That tool has been accessed by over 4 million users since it was launched. And based on feedback from users, we designed a website that builds on last year's effort. The new site includes an interactive snapshot of the latest state and local data, including COVID-19 wastewater levels, a weekly national summary of the latest findings in an easy-to-read format, current guidance to protect yourself and your community, and of course, timely data visualizations from key data sources. We're going to continue to improve the site throughout the fall, adding updated, up-to-date data on vaccine use, new wastewater level data for flu and RSV, and thanks to our partnership with CMS and hospitals across the country, new local hospitalization data. So stay tuned to check out those updates as we go into the fall. So what can you do with all that information? In March, CDC simplified its guidance to help people understand how they can avoid getting sick, and if they do get sick, prevent it from being spread to others. Our top recommendation for protecting yourself and others is to get an updated vaccine for COVID and flu. For the 24-25 respiratory virus season, CDC recommends everyone 6 months and older get an updated COVID vaccine and the updated flu vaccine. Both updated vaccines will start to be available at pharmacies and in your doctor's offices, so make a plan now to get your updated vaccine in September or October, ahead of the expected increases in both viruses this winter. In June, CDC also simplified our recommendations for RSV vaccines, so that everyone 75 and older should get an RSV vaccine, and people ages 60 to 74 who are at increased risk of severe RSV should get a vaccine. But note, these RSV vaccines are not currently an annual vaccine the way a flu vaccine is. So these recommendations are for folks who did not already get an RSV vaccine last year. So 1 dose of that RSV vaccine. And RSV immunizations also available for babies and some young children to protect them from severe RSV. And a RSV maternal vaccine is available for pregnant moms at weeks 32 to 36 weeks of pregnancy, so they can then pass on that protection to their baby. All of these vaccines prevent the worst of these infections. That means fewer visits to the doctor, fewer hospitalizations, and more time to enjoy the fall and winter with family and loved ones. Also a reminder, if you are sick, we encourage you to stay home. Keep those germs to yourself. Testing is also critical when sick so that you know what you have and can get treatment, particularly if you are over 65. We have effective treatment for both flu and COVID, but it needs to be taken early in the course of your illness. Finally, with the end of the Bridge program, CDC has identified an additional $62 million for state and local immunization programs to buy COVID vaccines this respiratory season, which will improve access to vaccines for the uninsured and underinsured adults. We anticipate additional funding coming to community-based organizations to continue to help get the word out to populations that public health may not be able to reach. In terms of what we expect from the flu, COVID, and RSV season coming up, CDC's Center for Forecasting and Analytics, otherwise known as CFA, pulled together a fall-winter virus outlook, examining historical data and scenario modeling. And based on all of that information analyzed and consultation with experts, CDC projects that this respiratory season will have a similar or lower number of combined peak hospitalizations across COVID, flu, and RSV compared to last year. Now, that being said, there are a lot of assumptions that go into a projection like that disposal to prevent disease. If those assumptions prove wrong, say, for example, the number of people who ultimately get vaccinated against flu, COVID, and RSV is lower than expected, then that could mean more hospitalizations, not fewer. So the power's in our hands. Changes to the virus that causes COVID-19 could also drive increased disease severity. So again, it's important to stay vigilant and to use the tools we have to keep ourselves safe and healthy. Now, I want to hand it over to my colleague, Assistant Secretary for Preparedness and Response, Dawn O'Connell, to talk about her efforts to prepare for this year's respiratory virus season. Over to you, Dawn.
Great. Thanks so much, Mandy. And thanks to all of you for joining us today as we discuss the preparations we have made for the upcoming fall and winter respiratory season. At ASPR, we continue to provide many of the tools necessary to protect Americans from COVID-19. I'm pleased to announce that ASPR's free at-home COVID-19 test delivery program will reopen in late September. As families start to move indoors this fall and begin spending time with their loved ones, both very old and very young, they will once again have the opportunity to order up to 4 new COVID-19 tests free of charge and have them sent directly to their homes. These tests will help keep families and their loved ones safe this fall and winter season. This is the 7th time over the last 3 years that the Biden-Harris administration has given families the opportunity to order the over-the-counter COVID-19 test for free through covidtest.gov. These tests will detect the currently circulating COVID-19 variants. Since the program started in 2021, ASPR has provided more than 1.8 billion over-the-counter COVID-19 tests to Americans. So far, more than 900 million at-home tests have been distributed through the covidtest.gov program in partnership with our colleagues at the U.S. Postal Service. In addition, ASPR has distributed 900 million at-home tests through community-based access points. These tests have been sent to long-term care centers, food banks, libraries, and many other community-based locations. So as all of you prepare for travel and gatherings with family and friends throughout the 2024 holiday season, don't forget to go to covidtest.gov to order your free tests. And even more importantly, don't forget to use these free tests when you are concerned that you or your loved one may have COVID. They will do no one any good sitting in your medicine cabinet. Taking a quick test is a great way for all of us to keep our friends, family, and loved ones protected as we gather to celebrate the holidays. In addition to these free tests, which let us know who does and who does not have COVID, access to treatments is important for those that do have the virus. So I also want to highlight the patient assistance programs we have worked to make available for COVID-19 antiviral medications. The PAXIS program is the U.S. government patient assistance program operated by Pfizer. And through this program, Paxlovid is available for free through 2024 for individuals on Medicare, Medicaid, and those who are uninsured. And then beginning in 2025 and running through 2028, Pfizer will take over the patient assistance program for individuals who are underinsured and continue to provide access to HHS procured Paxlovid. In addition to these programs, Pfizer also offers a copay savings program for eligible privately insured patients. And ASPR has secured a stockpile of 1 million treatment courses of Paxlovid, which should we see future surges in demand that overwhelm commercial distribution, we will be able to deploy those doses. This stockpile in the PAXIS program have roots in the work that ASPR and Pfizer have been doing together since the earliest days of the COVID-19 pandemic. And I also want to mention Merck's patient assistance program, which is called Merck Helps. This program provides free Lagevrio for people who are uninsured or who would otherwise not be able to afford the antiviral if not for the assistance that Merck Helps provides. In addition to Merck Helps, Merck also offers copay savings programs for eligible privately insured patients. Distributing at-home tests and securing access to treatments is an essential part of the Biden-Harris administration's efforts to ensure that we are as prepared as possible for the upcoming fall and winter respiratory season. I'm pleased to have this opportunity to tell you about the work that we're doing here at ASPR to support these efforts. And I'm proud to be working with colleagues across the government and in communities to protect the U.S. public ahead of the fall and winter season. And with that, I want to thank you for your attention and turn it over to Peter Marks with the FDA.
Thanks very much, Dawn. Good morning, and thanks very much for the opportunity to participate in today's conversation. As you know, vaccination remains one of the best measures for combating vaccine-preventable diseases. Yesterday, the FDA approved and authorized updated RNA vaccines for COVID to include a monovalent or single component to more closely target currently circulating SARS coronavirus 2 variants and to provide better protection against serious consequences of COVID-19, including hospitalization and death. The updated COVID-19 vaccines include Comirnaty and Spikevax, both of which are approved for individuals 12 years of age and older, and the Moderna COVID-19 vaccine and Pfizer-BioNTech COVID-19 vaccine, both of which are authorized for emergency use for individuals 6 months through 11 years of age. And here are some of the specifics for those who are eligible for these updated vaccines. So we'll start with younger children. For unvaccinated individuals 6 months through 4 years of age, they're eligible to receive 3 doses of the updated authorized Pfizer-BioNTech COVID-19 vaccine or 2 doses of the updated authorized Moderna COVID-19 vaccine. Individuals 6 months through 4 years of age who have previously been vaccinated against COVID-19 are eligible to receive 1 or 2 doses of the updated authorized Moderna or Pfizer-BioNTech COVID-19 vaccines, and the timing and number of doses to administer depends on the previous COVID-19 vaccine received. Individuals 5 years through 11 years of age, regardless of previous vaccination status, are eligible to receive a single dose of the updated authorized Moderna or Pfizer-BioNTech COVID-19 vaccines, and if previously vaccinated, the dose is administered at least 2 months after the last dose of any COVID-19 vaccine. So moving on to older adults, so older children and adults, individuals 12 years of age and older are eligible to receive a single dose of the updated approved Comirnaty or the updated approved Spikevax vaccines. And if previously vaccinated, the dose is administered, again, at least 2 months since the last dose of any COVID-19 vaccine. And finally, additional doses are authorized for certain immunocompromised individuals as described in the Moderna or Pfizer-BioNTech COVID-19 vaccine fact sheets. So based on the available evidence, it's expected that the updated vaccines will provide good protection against COVID-19 from the currently circulating variants as we transition into fall and head into 2025. FDA is confident in the safety and effectiveness of these updated vaccines, and they fully meet the agency's rigorous scientific standards, including those for manufacturing quality. Just to put things in perspective, the mRNA COVID-19 vaccines have been administered to hundreds of millions of people in the United States, and the benefits of these vaccines continue to outweigh their risks for individuals 6 months of age and older. Given the waning immunity of the population from previous exposure to the virus and from prior vaccination, we strongly encourage those who are eligible to consider receiving an updated COVID-19 vaccine to provide better protection against currently circulating variants. It's our hope that we can provide the information to healthcare providers and to the eligible populations so that individuals can make informed choices regarding vaccination based on the information that they receive. Hopefully, with good vaccine uptake in the overall population, we'll reduce lost productivity due to acute and to long COVID-19, and also to reduce medical care utilization, including emergency room visits and hospitalizations, as well as, of course, reduce the loss of life. Thank you for listening, and I'll look forward to questions at that time.
Great, thank you. Jeff Nesbitt from HHS.
Great,
Thanks, Peter. Thanks, Kevin. So last fall and winter, more than 10% of the U.S. population had the flu. At the peak of the respiratory illness season, more than 2,500 people a week were dying from COVID-19. As people get older, their risk for severe illness from respiratory viruses increases. Most hospitalizations and deaths from these viruses are among adults ages 60 and older. Infants are also at risk from respiratory viruses. RSV is the most common cause of infant hospitalization, but maternal vaccines can reduce this risk. People who live in nursing homes are already medically vulnerable, and shared living spaces are more likely to expose them to these viruses. Given this backdrop, we're excited about the launch of an important public education campaign to help reduce the effects that respiratory viruses have on people in the United States. Flu, COVID-19, and RS vaccines help people risk less severe illness and do more of what they enjoy. Yet many people are unaware of the tremendous benefits of these vaccines. HHS's new national campaign is called Risk Less, Do More. It prioritizes audiences at high risk for flu, COVID-19, and RSV. It's designed to inform key audiences about the risks of respiratory viruses and empower them to protect themselves from flu, COVID-19, and RSV. The national campaign's primary audience targets are older adults, as well as their caregivers and healthcare providers. Risk Less, Do More launched this month before the release of the 2024-2025 flu and COVID-19 vaccines. It will run through the winter of 2025. The campaign delivers research-based messages through national paid, earned, and owned media. The campaign is partnering with national, state, and local organizations to make sure as many people as possible have access to critical information that will help protect themselves, their families, and their communities from these contagious viruses. To reduce risk among other audiences with higher infection rates or lower access to healthcare resources, the campaign includes tailored messages for people living in rural areas, Black and Latino populations, and pregnant people who can help protect their babies. Risk Less, Do More shares research-based messages through media that includes TV, radio, print, social, other digital, and out-of-home platforms. The campaign's brand emphasizes that some people live with a greater risk of severe illness or death from respiratory viruses, but getting this season's vaccines reduces their risk so they can continue doing the things they love. Risk Less, Do More uses uplifting, relatable, and unexpected messages to reach at-risk people and connect preventative steps like vaccines to meaningful moments in our lives. Thanks. Back to you, Kevin.
Great. Thank you, Jeff. Okay, now if folks can use the raise hand function, just a reminder, and we'll then be able to call on you. Once we do call on you, if you'll just unmute your line, you'll be able to ask your question. And if you could please indicate who your question is for. So we're going to go ahead and start with Ron Lin from the LA Times.
Hey, thanks so much. This is for Dr. Cohen. A couple things. Can you talk about whether it's okay or recommended to get vaccines like COVID, flu, RSV, and shingles at the same time? And can you talk about whether we're getting to the point where COVID is equivalent in risk to the flu, or is it still worse than the flu? And then there was some garble, Dr. Cohen, from your forecast of what this winter is going to look like. Is it, if it's going to be even or better than last winter, is it because this summer was so bad from an infection standpoint? Thank you.
Great. So let me take them in order. So first, yes, you absolutely can get COVID, flu vaccines at the same time. It is a best practice. We want folks to get both the updated COVID vaccine and the updated flu vaccine. So yes, you can get them at the same time. And as far as the overall outlook, sorry for the glitch there. So our Center for Forecasting and Analytics looked at historical data, consulted with experts, and basically their outlook going forward is that this season we can expect a similar or slightly improved in terms of peak hospitalizations that we saw last year when you look at combined COVID, flu, and RSV together. But I do want to reiterate that there are, a number of assumptions built into that, including that folks go and get vaccinated. And that's why you're hearing so much preparation on our part, both from the operations, the education, to make sure that folks do take the important and best defense that they can get going into this season.
And then Dr. Cohen, I think there was one additional question, that's a three-parter there about disease severity, flu versus COVID.
Oh, yes, sorry, my fault. So we have, the virus continues to change, COVID virus continues to change faster than the flu virus, but we have some underlying protection because of prior infection, because of past immunizations. And so the severity of illness has decreased, which is why when we see high numbers of infection over the course of this summer, but we're seeing less corresponding hospitalizations and death. But the severity of COVID looks more similar to flu, but if you still put head to head flu and COVID in terms of what is hospitalizing more folks and what is killing more folks, COVID, it continues to be a more dangerous virus than flu. Again, they're becoming more similar, which is why earlier this year in March, we combined our guidance across COVID, flu, and RSV, highlighting the fact that vaccine is the most effective thing we can all do to protect ourselves and our loved ones. So they're more similar than they have been in the past, but if you head to head them, COVID is over the course of a year.
Great, thank you. Okay, Helen Branswell from STAT, please.
Thank you very much for taking my questions. A couple, please. The first would be to probably Dr. Marks. As Dr. Cohen just said, the COVID virus, the SARS-2 virus, is still evolving faster than flu, and yet we are treating COVID vaccine production like flu production. The two of them have almost been synced so that they're both available at the same time. Is there any thought being given to asking manufacturers to produce updated vaccines maybe twice a year or something? I mean, we certainly have more than one surge of cases in a year. And the other question probably would be for CDC. I don't think I heard anything about availability of nirsevimab. Do you have any estimates of how much product there will be, and how well the systems are now developed to get that into kids this fall? Thank you.
So Helen, thanks very much for that question. Let me start with your point is very well taken about a virus that continues to evolve. And we obviously, in conjunction with our CDC colleagues, keep track of its evolution. Were there to be some tremendous evolution of this virus such that we thought that the protection provided by the vaccine was no longer present, we might obviously consider at something other than an annual update. But the current problem is not that the virus is evolving so much, at least in terms of my estimation. It's that we don't have the benefits of the vaccine, which is that it's not vaccines that prevent disease, it's vaccination. It's getting vaccines in arms. And so I think the point of this campaign is that if you have someone in the office and you can get them to get a COVID-19 vaccine while they're getting their flu vaccine, and we get that immunity into them, that is probably better even than what we have now, which is people who haven't had a COVID-19 vaccine for 1 or 2 years. So I think that is the point here, I think, of kind of, even though COVID is not the flu, being able to get that shot in the arm is what we really need to have happen. I think that's the point of this campaign here. And you have our word that we're going to continue to monitoring this. And if something were to, if there were a new mutation in this virus that were really concerning, we would have a conversation with the manufacturers about whether we needed to produce another vaccine, or whether we'd have a conversation with CDC about whether an additional dose of the existing vaccine could be beneficial. And I think I'll turn it over to Dr. Cohen for the next part of the question.
Great. Thanks, Peter. And Helen, just to build on that answer again, I think Peter hit on it at the end. Just two things. One, first, we continue to see the highest amount of hospitalizations and death from COVID happening in the winter months. And so getting that most updated vaccine prior to those months continues to mending. Second, we already recommend a second dose or a boost up dose with the same version of that vaccine 6 months after first if you are at higher risk. So again, encouraging folks who may be at higher risk to make sure they're getting the most protection that they can, and to talk to their doctor about whether that's appropriate. On the nirsevimab side, we have been very closely in touch with the manufacturers to make sure that the supply is there to protect our babies from RSV. We meet with them quite frequently. In fact, I went to a fill finish factory to observe the work that was being done. As of right now, what they report to us is that we are on track to have the supply that we need to protect our children. Of course, there are steps that continue to need to be complete. We want to be using nirsevimab closer to the October timeframe for our babies when we start to see RSV. So we still have some additional time here in the manufacturing and approval process.
Great, thank you. Okay, Brenda Goodman from CNN.
Hi, thanks for taking my question. The first question is about vaccines for lower income people. I was going to ask about the Bridge Access Program, and it sounds like that's gone away. But can you elaborate a little bit, Dr. Cohen, on what is available for people that can't afford to pay for a vaccine?
Yes, thanks, Brenda. Yes, unfortunately, the Bridge program was sunset because of rescissions, but we were able to identify an additional $62 million that we put into what's called the 317 program, and it allows our state and local immunization programs to purchase COVID vaccines for the uninsured and the underinsured. But so I would encourage folks to be reaching out to their local public health departments, their state public health departments, but in addition, also their federally qualified health centers as well. So those are opportunities. Again, those with insurance, Medicare, Medicaid, private insurance continue to have these vaccines covered. Of course, the Vaccines for Children's program covers vaccines for all children, but we do not have that corresponding for adults. So adults should be getting in touch with their local and state public health departments and with federally qualified health centers.
And then if I could follow up with just one quick question, I wondered if Don O'Connell could tell us how many tests are available to order. It's great to hear that program is back. And then just where does the funding, are these new tests or are these leftover tests that were deemed to still be effective?
Yeah, I can take that one. Thanks, Brenda. I'm David Boucher, Director of Infectious Disease Preparedness and Response here at ASPR. Typically in our prior rounds for covidtest.gov, we range anywhere from about 50 to 75 million tests. We have quite a bit of supply in the Strategic National Stockpile available to support that. So we won't have any inventory issues. We'll be able to supply those. When people log on to covidtest.gov, they'll be able to order 4 tests at a time.
Thank you.
Mm-hmm.
Okay, thank you. All right, Fennett from Washington Post.
Hi, thank you for doing this. How should we look at our individual risk of severe disease if we don't get this updated vaccine? Because hospitalizations were low despite the poor uptake of the 23-24 vaccine. We hear that our immunity is getting better from our past vaccines and infections. So is there really a danger here of not getting the new vaccine, especially if you're not in one of these high-risk groups? And then a question to Don O'Connell. Why didn't we restart the free COVID test program when we had this summer wave?
I'll start with individual risk, and maybe Peter might want to add as well. First, I think it's important to understand that the virus is changing, but also the protection that we get from past infection or past vaccines wanes over time. So you want to make sure that you are getting the highest level of protection you possibly can going into a season where we know we'll see more of the COVID virus circulating, the flu virus circulating. And these are things, if we can be effective at having the best defense we can about going to the hospital and having our lives taken from these viruses, we want folks to take advantage of that. I will be getting vaccinated. My daughters who are 10 and 12 will be getting vaccinated. My parents, of course, who are over 65. Now, individual risk does vary, but there is no group that is without risk. And that is what our data continues to show. Those over 65 are at highest risk. Those with underlying conditions are at increased risk. And remember, half the adults, more than that, 80% of the adults in the country have some sort of underlying condition that could put them at some sort of increased risk. And lastly, I'll just mention the wave we saw this summer of COVID infections. When we look at who went to the emergency room for COVID, we actually saw that it was highest for those under the age of 5. So I think we've been definitely know that this impacts those over 65 with, that they're at highest risk, but we can't forget that at every age group there are risks, including our young children. Peter, anything you'd add there?
Yeah, so I just want to add something that I believe, in hearing some of the news coverage yesterday, something that continues to be forgotten is that the only way you get long COVID is by having COVID. And vaccines can help prevent COVID. So there are actually some studies that have come out, one just more recently, but several from over the past few years, which clearly show that those who are vaccinated, whether it's one vaccine, two vaccines, or three vaccines, have a lower risk of long COVID. And so even if, at least personally, I have a tremendous empathy having seen people struggle with long COVID in their 30s and 40s, people who you might think were otherwise low risk. And I would suggest that if I could reduce that risk by 50%, which is the estimate by which vaccination seems to reduce that, I think I would want to take, at least personally, avail myself of the benefits of vaccination. Thanks.
David?
Yeah, Kevin, I can take. Oh, sorry, Dr. Cohen.
Nope, I was turning over to you. Go for it.
Yeah, so to pick up on the testing, Finnan, it's a great question. I think with the resources we have available for COVID, we need to be a little bit strategic. When we thought about when to launch round 7 of covidtest.gov, we thought it's the right time as people start to travel, as they start to get together with friends and family through the holidays, want them to have those 4 tests available to them at that time. It's a great opportunity also for me to mention that we've sent out just under 2 billion tests since we started doing this. Only about half of them go out through covidtest.gov. We have several other distribution channels. The tests that you see in schools, libraries, long-term care facilities, food banks, community centers, that type of thing, where they're close to people's homes. Those distribution channels don't pause. They've been active since we started. They go year round. So another way for people to get free tests throughout the year, not just when covidtest.gov is open.
And if I can squeeze in one more, with the vaccine effectiveness data showing that updated vaccines really start to decline off after 4 months, does it make more sense to get the new vaccines in October when we've seen winter waves pick up in November and December in past years?
So we're recommending folks September, October. Those are a good time to get vaccinated. The important part is getting it done. So if September from a calendar perspective works better for folks, great.
Covering a virus that is continuing to evolve. And it is likely that what is going to be there in 4 or 5 months from now will further evolve from where it is now. Now, getting vaccinated a little later probably will help protect against it then too, but the getting vaccinated now probably gives you the maximum amount of protection that you can get against what's currently circulating, and that will last for several months at least. I think it is a matter of personal choice. But at least I think Dr. Cohen noted, and I can tell you, I already have my appointment.
Right. Thank you. Okay, Alex Tin from CBS.
Hey, thanks for taking the time to do this. For Dr. Marks, on the decision to go with KP.2 in the vaccines over JN.1, do you have any data to suggest that was the right move, given what's currently dominant? And then for CDC, I'm wondering if you can just tell us, do you think we have passed the peak on the current summer wave, and how much COVID vaccine uptake is expected in that outlook? Thanks.
Yeah, thanks so much. I think there is the data that we have is honestly soft. I think whether it's a JN1 or a KP2 vaccine, getting either one of those in your arm is a good idea. There are a small amount of data that have come out from laboratories. It's serology data, not clinical trial data, that suggests that perhaps the KP2 vaccine may provide a modest additional amount of protection, but we'll have to gather those data as the season goes on. And at this point, I know some of our European colleagues are going to be receiving, in much of Europe, they may be using JN1. We'll have both JN1 and KP2 targeted vaccines here in the United States ultimately, and I think it just is a matter of getting one of them in your arm.
Great. And I will cover the where are we in terms of COVID trends right now, and I might ask Dr. Daskalakis to join me on this. So if you look at our wastewater data and our test data, it does look like there is a slowing increase, or that we are just either at the peak or just past the peak, depending on where you look across the country. Dr. Daskalakis?
Covered most of it. I'm just going to add that also on our website, in close collaboration with our Center for Forecast and Analytics, we also include an RT estimate of what's happening in the country, and sort of syncing to what Dr. Cohen said. About 24 states in the country are showing growth still, while other areas seem to be plateauing or decreasing. And so that actually compares to about 49 states sort of in the weeks before that were showing a growth estimate. So we're not out of the woods yet. We're tracking all of the indicators really closely. You heard about wastewater and test positivity, but I think we are potentially seeing some indication of a plateauing of the summer increase in COVID-19. Thanks.
And how much COVID vaccine uptake does the outlook expect? Sorry, that was the other question.
Sure. So if you look for the Center for Forecasting and Analytics, will put out a more detailed piece on all of what went into their assumptions, but essentially they looked at historical vaccination rates, and our vaccination rates are, continue to be lower than I want to see. So we're going to be working to get as many people vaccinated as possible. But what went into the forecast was based on historical vaccine uptake that we saw last season.
Thank you. All right, Erica Edwards from NBC. Erica, you just need to unmute yourself.
Can you hear me now?
Yep, we can hear you now.
Great. Thank you so much. The FDA approved Pfizer and Moderna's COVID vaccines, but not Novavax's. Can FDA talk a little bit more about the reason for that delay? Thank you.
So thanks, Erica, for that question. So we can't talk about an application that's pending, but what I can tell you is that obviously the COVID vaccines are very important. Any COVID vaccine would be something we would take action on as rapidly as we could based on any data submitted to us. And I would suggest that you contact any vaccine company that you have questions about the status of their application. Thanks.
Great, thank you. Okay, Teddy Rosenbluth from the Raleigh News and Observer.
Hey, sorry, I'm actually from the New York Times now.
Sorry.
This is probably a question for Dr. Cohen. Would you say that COVID is officially endemic now?
COVID's with us. Yes, so COVID is circulating with us, and why we've made incredible progress in being able to make sure that we're prepared, which is, what we were trying to outline for you today. It is still here with us. And as we've been saying, it is changing faster than even the flu virus. So we need to continue to be vigilant. But yes, is it endemic? It is here with us. We need to protect ourselves. And we have the tools to do it. We just need to use them.
All right. Thank you. Yuri, ABC News.
Thanks for taking my question. It's for Dr. Cohen. As we get into flu season, is CDC prepared to be able to differentiate cases of bird flu versus seasonal flu in the data sources you have at your disposal? And can you just outline the steps on how you're going to be able to do that?
Sure, I may have Dr. Daskalakis add details here, but flu is something we have been detecting and subtyping for many, many years, and we continue to be able to pick up seasonal flu as well as the other subtypes of flu, whether it's your case of swine flu just the other week. And our network of flu laboratories are able to pick that up and subtype that. But in addition, we also are adding the ability for our commercial labs to be able to test for H5 specifically. So, of course, they can test for the seasonal flus, A's and B, but they will be able to test for H5 in our commercial lab by the time we are into flu season. So we feel quite good about being able to differentiate seasonal flu versus some of the subtypes like avian or swine flu. And let me just see if Dr. Daskalakis wants to correct or change anything I've said.
A little bit more detail on the normal flu surveillance system. So since February 2024, the flu surveillance system has actually tested over 41,000 human samples, looking for what's circulating in terms of flu, differentiating seasonal versus non-seasonal. And in that mix, as Dr. Cohen said, it does continue to detect needles in haystacks. So we're able to identify swine flu, or up to 6 cases that have been identified using that system. To date, that system has not detected any H5, but as flu testing increases, that system is designed to also increase in volume. So we're going to be continuing to do that work sort of on the industrial strength scale to identify any H5 circulating in the community. That's further supplemented by the work that we'll be doing with farm workers, as well as what you heard already about scaling up testing, because along with the sort of industrial strength flu surveillance that we do and do consistently, we're also making sure that if we hear of individuals who have an exposure, that we work closely with our local and state health departments to monitor them, since that is very high yield in us identifying individuals with H5 infection. Over. Thank you.
Thank you. Okay, Danny Blum from New York Times.
Hi, this is for the CDC. I just wanted to ask if there's been any update in how we should think about reinfection and the cumulative risks of getting like a 3rd, 4th, or 5th case of COVID, even if someone has a mild go of it. Are we learning anything new about that health toll of cumulative reinfection?
So every time your body encounters a germ, a virus, a bacteria, you are creating antibodies that allows your body to identify something similar to that going forward, which is why earlier on in the conversation here, when we are seeing this change in trend where we're still seeing high amount of COVID circulating, but not as many people going to the hospital or dying, it's because we have that underlying protection, either from previous infection or previous vaccination. So again, when we've had multiple opportunities for our body to see these viruses, it allows us to build underlying immunity. However, the virus keeps changing, and that underlying antibodies and immunity does decrease over time. Again, this is why we're recommending the updated COVID vaccine for everyone, to boost up your protection, to match it to what's circulating. And then to Peter's very good point, is we want folks not just to be protected from hospitalizations and death, which is the most important, but also from things like long COVID, right? So even if you've had a mild course of COVID in the past, that does not mean you wouldn't get a long course of COVID going forward in the future. So cutting down your risk of getting COVID at all cuts down your risk of getting long COVID. So again, the past can help going forward into the future. future. But again, those can wane over time, and you want to make sure you are protecting yourself from things like long COVID.
Okay, thank you. Manas, I hope I'm pronouncing that right, from Reuters.
Thank you for taking my questions. I have one for the ASPR on Mpox. Just given the Mpox emergency and changes to the virus, do we know if there's any respiratory spread? And just to follow up, does the US plan to supplement its donations beyond the 50,000 doses to Africa?
Sure, I'll start there, and maybe, oh, good, David popped on maybe for the second question. On first, in terms of modes of transmission, we continue to see that there are two different versions of the Mpox virus, clade 1 and clade 2. But both versions of those viruses continue to look like they are spread through very close contact, sexual contact being the most likely. We are seeing some household very close contact spread in places like DRC with clade 1. But those dynamics we're still investigating those. We still have epidemiologists who are doing that work to understand it, but we are not seeing transmission in places like churches or markets or others that would make us think that there's some other transmission dynamics other than very close contact. So we continue to think that dynamic transmission here is very close contact, even with the more transmissible clade 1. David, do you want to address the donation?
Yeah, sure. Just really quick. So I think right now we've had 50,000 doses on the table for donation for a considerable amount of time right now. I think a lot of the focus for us is taking some of those and turning them actually into shots in arms, getting regulatory approval to import them into DRC, and then the implementation. We're working quite a bit with our international partners. There are quite a few groups who have equities in this space and obviously want to be respectful to the in-country personnel as this is their outbreak to manage. We want to make sure we give them assistance. That said, we are constantly looking at resources we might be able to bring to assist them in any way they need. Thanks.
Thank you, David. Okay, Josh from Barron's.
Oh, so my question's been answered. Thank you.
Okay, that is actually the end of our questions right now. I know that Jeff wanted to jump in with a final point before we go. So go ahead, Jeff.
Thanks. I just want to make sure everybody had a couple of websites in case you wanted more information. One is risklessdomore.hhs.gov. The second website is cdc.gov/risklessdomore. Both of those have quite a bit of additional information in case you need it. And second, this is mostly just for Brenda Goodman from CNN, but others who care. I just wanted to make sure that everybody was aware that the IRA, the Inflation Reduction Act law that President Biden and Vice President Harris negotiated, does allow for free vaccines for Medicare recipients. Just want to make sure that folks were aware of that. It's one of the special provisions under IRA. So thanks, Kevin.
All right. Thank you, everyone, for joining us. Obviously, if you have follow-up questions, you can follow up with us individually. So thank you again for your time, and have a good rest of your day.